The next talk is Living in a Shallow AC Hub, Dr. Monica Chetan. Dr. Monica Chetan is glaucoma consultant at Netradama Eye Hospital at Mysore.
Dr. Rajesh Sinha's talk, should we take or what?
Good morning, everyone. Thank you, AIOC, for giving this opportunity. The double trouble I'll be talking about would be, one of the trouble is the cataract, and the second is operating in a shallow anterior chamber. For the time constraint, I made into an audio-visual play. Can we have it, please?
Living in the shallow AC hub, the lessons my cataract cases have taught me. A safe surgery involves a proper pre-operative evaluation and preparation of the patient. Please give adequate importance to a good slit lamp examination, especially if attempts of PI has been made at multiple sites. A quick glance of the biometry is also important. On the day of the surgery, take care that the intraocular pressure is well maintained. One can be liberal with local anesthesia depending on the patient's cooperation and the eye condition. A vitreous dehydrating agent like mannitol and bristol can also be used to reduce the thrust. And finally, anticipate the difficulties that you can face at each step and modify each step accordingly for a safe surgery. My surgical approach to phaco in shallow AC. The sideport incisions have to be slightly inside the limbus and longer and parallel to the iris plane. Do not touch the iris or the capsule. In case of shallowing of AC during incision making, reform with BSS or visco. The main root should be also slightly inside the limbus and longer than normal. Do a proper aqueous replacement with a good viscoelastic to deepen the AC before making an adequate size of CCC. After CCC, it's important to burp the wound and decompress the AC before any hydro procedures. A gentle hydrodissection with as little fluid as possible is important, with subsequent decompression to release the trapped fluid. This prevents the rise in intracapsular pressure and prevents further AC shallowing and iris prolapse. During nucleus handling, we have to remember that such cases may be associated with high lens thickness or zonule laxity. So in shallow AC, it is essential to do chopping in the back and making as many small pieces as possible. Emulsification should be at the rhexis plane. Avoid any supracapsular method of phacoemulsification and anticipate zonular defects or weaknesses, especially at the site of. Once you remove a 4 to 5 mm lens, space issue is resolved to a great extent. Cortex removal and IOL implantation will be as routine in most cases. Except sometimes you can face a few rare incidences. A case of shallow anterior chamber post-PI, thrust was felt during phacoemulsification. After cortex removal, a purple-blue glow was seen in the vitreous cavity with thrust. This is probably due to the fluid and dye going into the vitreous cavity through lax zonules or PI. A few precautions that have to be taken during surgery. Iris can be your best friend or your worst enemy. Do not irritate it. This is one of my old cases showing the probe touching the iris during trenching and causing an intraoperative meiosis. Even if it happens, be careful and be prepared with intracameral adrenaline or pupil expander devices. Probably the most common issue we face during phacoemulsification in such cases is iris prolapse. It occurs due to the trapped viscoelastic or fluid below the iris. If you try to reposit it back with the probe like it's happening in this case, it will cause more prolapse of the iris. So do not go in with the phaco probe. Do not try to reposit the iris injecting viscoelastic from the same site. The ideal way to do it is pull the prolapsed iris in from a different incision and decompress it to release the trapped fluid or viscoelastic. Tamponade the iris with a little viscoelastic also from the main site. So in conclusion, I would say that phacoemulsification in shallow AC involves keeping friendship with and respecting the iris, maintaining an equal distance from the endothelium and the posterior capsule. Thank you. Living in the shallow AC hub, the lessons my cataract cases have taught me. A safe surgery involves a proper...
Thank you so much. It was a very nice one. I didn't know you could cover so many things in such a short time. I think Dr. Manisha, any comments you? Yeah, she's waiting.
Because okay. Shallow AC, so that is, in the huge area of interest. And you said PI and all that. So are they in angle closure glaucoma cases?
Yes, ma'am.
They are angle closure
Especially stay in
glaucoma.
Mysore where I face a lot of angle closure cases.
Yes, exactly.
So that's why I was
And I
emphasizing.
saw advanced cataract also. So wouldn't you like to go for, what I do is I go for a combined surgery in these patients, because even post-operative intraocular pressure fluctuates, and we know the fluctuation is really bad for the optic nerve head, right?
Yes, ma'am.
So is there any reason you're not doing a combined surgery
No, I
in
didn't
these?
put one of those. I put one in which the cataract was done. But of course, many a times when you saw in the biometry picture here, the lens thickness was around 5.2.
Correct.
AC depth was around 2.0.
Yes.
Makes all the sense to combine both and do it.
And the
because
other-
after replacing a thicker lens, which is thinner one, and making more space for the fluid to pass.
Exactly.
I didn't put one of those videos. This was just a pure cataract. But I do take your point, ma'am.
And the other thing is that being a glaucoma surgeon, I'm sure you're doing glaucoma surgery, aren't we stingy about keeping a space for the blood for future
Of
glaucoma
course, ma'am.
surgery? No?
Always,
So then we
always.
have actually made a side port and the incision. So I don't know, I would go for a combined surgery, right?
This case was not actually a glaucoma case. Like these are
Okay,
some.
you said PI, no, in all the patients.
Ma'am, that was
Okay.
just to prepare if any patient with shallow ACs are there, any other case. This was not specifically a glaucoma case. Otherwise, of course, ma'am, the handling of the conjunctiva, irrespective of whether actually he has glaucoma today or he develops tomorrow, we don't know. We have to give respect to the tissue.
Thank you.
But in a lens thickness which is high, won't it be better to do the cataract surgery alone first to see what's the post-op response in terms of IOP control and then plan for a combined
So this we
procedure?
used to do several years ago. Then I realized that our patients, I have a large series on that 50 plus club. They come at undiagnosed glaucoma, advanced. So both eyes, swollen lens, mature cataract, you cannot even evaluate the optic nerve head. And the pressure is above 50, they're unaware. So in these cases, I do a W trabeculectomy. And if they can afford an Ologen implant, I do an Ologen implant. I have a series over several years of 90 patients. So they respond, that's the only surgery because you make such a big window that they respond to that, and advanced cataract already when they...
No, I was just talking about the advanced cataract with the thick lens.
So the
wherein if
pressure fluctuation post-operatively, few of them turn out to be steroid responders also. So whatever is left of the optic nerve head is further damaged, because the evaluation is very difficult in these cases with mature cataract of what the state of optic nerve head is.
You can take care of pressure by putting drops. No?
No, sir, but post-operatively,
Yeah,
there is a
Please go ahead.
fluctuation, large fluctuation.
Because as such narrow angle closure glaucomas, just even people have done clear lens extraction also to create the space.
If the angle is just apposition
I think, sir, it will depend also on the
Yeah,
gonioscope.
yeah. Once it's anechial, then there's no point. If the idea is just to take care of the appositional, to reduce the thickness of whatever is there, so that the iris falls back. That's the basic idea.
Although we are glaucoma surgeons, we are just not trigger happy. We try, if this patient will respond without the combined surgery.
Maybe glaucoma surgeons are more biased towards doing trabeculectomy.
Come in here.
Blanket rule of doing grabs for, because if the optic nerve head is looking healthy, just for shallow
We
AC.
can't see it. I'm talking only about these cases.
No. This was not a
I think-
glaucoma case, sir.
I think decision
the
should be
three-
based on gonioscopy.
I think the
No,
3
I-
points would be the IOP and the gonioscopy.
And the optic
If you do not have pass for more than 2/3, then it doesn't make sense to go for trabeculectomy. I think the message is taken little different. This was not a glaucoma. It was like shallow AC. So I think the 3 points are the IOP, the gonioscopy, and the optic nerve head. Otherwise, there's no sense to do both together. No.
And
That's
just one point I would like to add, that in such shallow chambers, the main incision I would like to put a little anterior, so that the risk of iris prolapse in the post-op, in the intra-op period is less.
It's very troubling that iris prolapse.
coming one.
Yeah, I think for the iris prolapse, I think one thing which works out very well is using a viscoat-like things. No, it actually goes to the angle and keeps it the iris well away. So I liberally use viscoat multiple times, and it really gives. One thing is the chamber is narrow, small, so the endothelium gets well coated, angle is well protected, iris doesn't come out. So using it is very, very important.
Is Orocoat, sir. works wonderfully well because it helps all the 3 parameters together, and it won't come out as a full bolus. So I think that's a good thing.
IV mannitol, has anybody given IV mannitol intraoperatively?
Pre-operative.
Only if the pressure is high,
Pre-op.
then only, pre-op only, but only if the pressure is high. Otherwise,
Again, the gonio findings, the lens thickness, the pressure, what you're anticipating from the patient, all that has to be taken into account.
And other thing, probably we have to keep in mind in these patients is very shallow AC, might require some vitrectomy as well.
I think that will be covered by Dr. Mithun Pai, because I showed one fluid misdirection, he has that case only. So he'll be showing that.
Dr. Suresh, would
Suresh.
you prefer to do a PI in this patient because if there is
If
positional closure in that?
I feel quite a lot of things go based on the confidence of the surgeon in handling a shallow AC. Because once a patient of shallow AC is operated, more likely than not, the AC is going to deepen. So, if I think you can confidently manage a shallow AC, you can just, in fact, you can use it as a treatment even for primary angle closures. Regarding the decision of doing a trab or not, it is based on so many other factors. Just having a shallow AC will not be a factor in taking a decision whether you want to combine trab. So another is chronicity of the situation. If at all in the intraocular pressure is high and the case has been very chronic, and if you have evidence that there is some significant damage to the optic nerve, these would rather bias you towards taking a decision whether you want to include trab.
it has to be case-based actually.
Yeah, case-based. Please go ahead. Last question I think we'll take and go ahead. Yeah.
Surgeons, this thing. Precautious use of Trypan blue is very, very important because few cases shallow AC, if you put too much of Trypan blue, it can hydrate the vitreous, there will be too much of pressure. Again, intraop hardening makes the shallow AC surgery difficult. So just go to the simple, put 1 drop of Trypan blue and move on to corrective. It should be
Yeah, I think even again that would be convenience and based on the type of cataract, whether it's mature, immature. Of course, yeah. One thing in your favor would be using Trypan blue makes the capsule more friable and more easy to it. But on the flip side, you can also see that, if there is a shallow AC and if in case there is bowing of the lens anteriorly, then it may also cause more easy runoff as well. But yes, visibility definitely gets enhanced significantly.
I meant to say, Trypan blue, we usually we inject it rather than injecting because Trypan blue is known to hydrate the vitreous and it can make the intraoperatively the hard eye.
Vitreous.
No, actually, what I could figure out is that these things do happen when you have a case which is operated in a vitrectomized eye, wherein there is some zonal deficiency, wherein you have the chance of aqueous misdirection, wherein if you inject Trypan blue excessively, then it will go posteriorly. I mean, that is what you meant, no?
Sir, I think you are meaning aqueous misdirection syndrome when you are irrigating. It's not because of Trypan blue.
Sometimes aged people, there can be zonus laxity where too much of Trypan can go into the vitreous and hydrate.
Why too much?
Any fluid, if it goes into
Any
vitreous, it
fluid
will
can cause
hydrate.
it.
It need not be only Trypan, it can be any fluid.
But we hardly put. What is the point is, I think the amount of dye that you are.
Injecting should be very
That
minimal.
should be very small. Exactly, you're
Because
right.
if you see in most
Yes,
people,
yes.
Behind an air bubble.
more
Correct.
It has to be behind an air bubble. You can't
single
put.
drop or 2 drops.
Yeah, I think that point is. That's the point.
See,
What we do is.
what happened in this case is the amount of Trypan blue I use is same for all cases, but this happens once in a year. So probably this is something else, but the message conveyed is do not go overboard with Trypan blue just for the sake of, I think that's good enough for the audience.
Yeah.
Point taken, I think.